So in today's topic, it's severe acute malnutrition, chapter 8, page 155 if you have the old textbook. Those who have the new textbook, please mention the page number in the chat box. Page 160 in new textbook. If anyone is joining late, please help them out with the page numbers. So severe acute malnutrition, it is defined as very low height and weight for children who are growing up, especially under the age of 5. They are at the highest risk of getting into severe acute malnutrition. Very low weight. They may have height, they may not have height, depending upon the type of malnutrition they have. In some cases, there will be severe muscle wasting. In some cases, there could be edema. The difference and all we'll see soon. Okay. So how do you check, like at home, or if you are traveling somewhere and you see a child who is visibly very small for its age? Okay. If you have a measuring tape, how do you check it? You take the mid upper arm circumference. Okay. First, you have to take the length of shoulder, tip of the shoulder to the elbow, divided by 2. Whatever is the length, at that length, you have to place the measuring tape to check the circumference. Okay. And if the circumference is less than 11.5 centimeter, it means the child is suffering from malnutrition. You can see the image here. Okay. Like this, if you place the circumference, and if the circumference of the mid upper arm is less than 11.5, high chances that the child has severe acute malnutrition. And this would work only for kids who are in the age group of 6 months to 5 years. Okay, 6 to 5 years. That is the age group in which this will work. Above 5 years, this method will not work. And usually, malnutrition, severe acute malnutrition, is seen in kids under the age of 5. So coming to the classification, Kwashiorkor and marasmus, these are the two main classifications. Clinical classification, you have severe wasting, which you can see in marasmus here. The child has no fat, no muscle layer. You can actually see the bones, the entire bone structure is very prominent. So this is a case of severe wasting. Okay, and that is what you call as marasmus. And then you have nutritional edema, the other situation here. You can see picture A. Kwashiorkor, ankles, the belly, face area. Okay, there are it is swollen. Okay, edema, swelling. That is nutritional edema. You see that in Kwashiorkor situations. Medical complications, you have uncomplicated severe acute malnutrition and complicated. Uncomplicated, usually at home you can solve. Okay, you don't require to get admitted in the hospital. You can visit the clinics, primary healthcare center regularly for follow-up. Okay, but no need to get admitted. So that is uncomplicated. Okay, the child may not have severe infection or hypothermia, hypoglycemia. These kind of situation will not be there. The child can survive, and with home-based remedies and a health education given by the physician, if the parents are following it. Okay, at home itself, through a domiciliary care itself, the child can recover. And complicated, you will require the child to be admitted. Okay, otherwise the situation could be fatal. You will lose the life of the child. Okay, that is complicated severe acute malnutrition. Hypothermia, severe vomiting, infection, septicemia, dehydration, metabolic disturbances. These all are some complications that can take the life away of the child. Okay. So coming to the clinical features, yeah, from this in exams questions may come. Okay, clinical features of marasmus and kwashiorkor. Okay, so you should know exactly what all are the clinical features in these two disease conditions. Okay, so when it comes to marasmus, you can see it usually happens in children who are less than 1 year of age. And kwashiorkor, the name meaning also of kwashiorkor means elder child. So that takes place in kids who are in the age group of 3 to 6 years. Okay. But marasmus is very common in kids who are under the age of 1. Okay. Usually, but it can happen in other age groups as well. But usually we see it is under the age of 1. Those kids are affected by marasmus. And this happens due to low calorie intake, severe growth retardation. The child will not grow in height. Okay, reduction in body weight because the child is losing the subcutaneous fat as well, visceral fat, muscle layers. Okay, everything the child is losing. So there will be a severe reduction in body weight, shrunken abdomen, subcutaneous fat which is not preserved. So because subcutaneous fat is there between your upper layer of the skin, your muscles. Okay, and muscles are also not there, the fat layer is also not there. Now definitely your bone structure will be very evident through the skin. That is prominent ribs. Voracious feeder, they are very hungry, they consume a lot, but that is not getting absorbed in the body because the intestine is hypofunctional. Okay, no, there is no fatty liver here because whatever fat deposits are there, it is all taken up, used up by the body. Okay, the body is in a severe catabolic stage. So there is no situation called fatty liver. Edema is not present here. There is no swelling as well. Okay, if the swelling was there, you would not see the bones because you can see the bones means there is no swelling. And old man like face, wrinkled, all the fat has been lost. You can see in old age also they lose all the fat from the body and the skin becomes very loose and shrunken and wrinkled. Okay, the same effect you will see here as well. And there is no hair change, dry wrinkled skin. They are alert but they are very irritable. Okay, easily they will cry and requires adequate amount of protein, fat, carbohydrate to develop back into normal. Okay, so all the macros, proteins, fat, carbohydrate, all of these are required for this child to come back to normal. Okay, at least to catch up with the growth. All these macros are required. Coming to kwashiorkor. So this can usually happen in kids who are in the preschool category, 1 to 5 years of age. And usually it is between 3 to 5 that we see most of the cases. And it is because of low protein intake and mild growth retardation is also there, mild reduction in body weight, but it is not too much because of the edema, it seems like the child has not lost weight. Okay, because of the swelling, it feels like the child has not lost a lot of weight. There is a protruding abdomen. The fat loss is not there here, so the child is retaining the subcutaneous fat. Okay, there is no fat loss. Ribs are not prominent here, and the child has a very poor appetite. The child will not eat. Unlike in marasmus, the child will eat a lot. It's a voracious feeder. But in kwashiorkor, the child will not have the appetite. Here, the child will suffer from fatty liver as well because the fat is getting deposited. Edema is present. Moon face, because the face out of swelling, the face becomes like a moon face, completely rounded out of swelling. Very sparse hair, flaky paint like skin. They are very lethargic, requires adequate amount of protein. Their focus is here on protein. They have fat in their body, they have carbohydrates as well, but protein is what they have to focus on when it comes to getting back to their growth. Okay, so these are the main differences between kwashiorkor and marasmus. And then we have something that happens in the middle. Okay, that is marasmic kwashiorkor. So in marasmic kwashiorkor, it will have, just like the name how it suggests, it will have clinical features of both. Okay, there will be edema that comes from kwashiorkor, and there will be also prominent bones that you can see. Okay, severe muscle wasting and bony prominence is also there because of the marasma. Okay, and usually it happens in children who are between 1 to 3 years of age, exactly between the most common marasmic age and most common kwashiorkor age. Okay, that is 1 to 3 years of age. So key features, they will have edema in the feet and the lower limbs, the lower hands, okay, but the upper arm, upper legs will be very thin. Okay, bones will be visible, pale skin. The child is unhappy, irritable here. Okay, muscle wasting is also there, but edema is also there. Okay, so both the features will be seen here. And other types of growth retardation you can see, in which in some situation height is affected, in some situation height is not affected. This is a normal child. All these three kids are of the same age. Okay, so in stunted child you can see visibly the child is lighter, so the weight is also low, and the height is also there. The child is not catching up with the growth, right? So here you can see height is also not there. On top of that, weight is also not there. Okay. In wasted child, you can see there is severe wasting. If you compare this child to a normal child, height is not that much affected. Definitely, little bit the child is smaller, but it's not a very stark difference. Okay, this level of difference is usually seen in all the kids. Okay, but the other major difference you see here is the bones. It's the child on the right is pretty much wasted as compared to the normal child. Okay, the body, the fat, the muscle structure, okay, muscles and all, the child does not have it. The child has lost it. Okay, so that is a child who is wasted. Okay. So these are the different types of childhood malnutrition. A normal child is of a particular height and weight. A wasted child has the normal height, but they don't have the weight. They are severely underweight. Stunted child, slightly they are lighter. Their weight is okay by with respect to their height, but their height is not okay at all with respect to their age. Okay, they don't have height of a normal age. Underweight, slightly they are lighter and slightly they are lower in height. Okay, but there is no severity. You will not see major complications in underweight. Okay, with proper nutrition at home based care, underweight kids can catch up, okay, with their normal peers. So coming to the changes in the organ system internally, what happens to kids who suffer from these disease conditions? Digestive organs, pancreas, intestine, they all get shrunk, okay, uh, smaller in size, and their function also get lesser. They are not as functional, they are less functional. The type of enzymes your digestive system is supposed to release, okay, digestive juices and enzyme which is supposed to release, the mucus that it is supposed to form and release, everything goes down. Okay, muscles of your intestine also goes down. They atrophize, okay, they shrunk. So because of it, nutrient absorption will not take place. Nutrient absorption will be affected. Liver fat accumulates in case of kwashiorkor. Not in marasmus, but in kwashiorkor, fat droplets will accumulate in the liver cell, leading to fatty liver if it is untreated. Cardiovascular system, atrophy of the heart reduces the cardiac output and there is poor circulation. Extremities are cold, cyanized, and cyanized means they don't have enough blood circulation, lack of oxygen. And whenever you have a lack of oxygen in a certain part of your body, you will see that you will notice that area becomes bluish, purplish in color, okay, because of the lack of oxygenation. You hold your finger for a long time tightly, you can see that coldness coming, okay, when you stop the blood circulation, and slightly it will turn bluish, purplish in color. That is cyanosis, okay. So extremities usually they are very cold and they have this bluish tint because of the lack of oxygen and too much of carbon dioxide. Kidneys, mild albuminuria will be there, which is protein in urine. Okay, because GFR rate, glomerular filtration rate is affected and protein can easily seep through the nephrons and go into the urine. Immunity falls, okay. Thymus gland, tonsils, spleen, these all are lymphoid tissues. They become smaller. And if they become smaller, they will not be able to produce T lymphocytes, B lymphocytes, okay, in a normal amount. So definitely the child's immunity will be restricted, okay. They will be prone to catch infections pretty early as compared to other kids. Mental development, at DNA RNA level also, the absence of protein is impacted. There could be lack of protein synthesis from the DNA level. There will be lack of new brain cell development. Okay, reduction in glial cells. Protein, cholesterol, lipids are required for the production of brain cells. Okay, they are made up of fat cells. So that is required. So that will, those new brain cells will not develop and that will lead to dysfunction, mental dysfunction, mental retardation. Okay, these things can happen. Some kids, if they have not attained 1 year of age and they have marasmus, it will delay their walking ability, skills, reflexes, and other neuropathies will develop one after the other. Hormonal changes you can see on table 8.2. There is a table, effect of malnutrition on hormones. You can just go through that. Growth hormone and all, it goes down, which is very necessary during childhood. Growth hormone, those will go down. Coming to the biochemical and metabolic changes, physiological changes, what happens? Protein metabolism, the serum amino acid levels, okay, those will go down. That is, if there is no protein in the diet, no protein in the body, definitely wherever protein requirement is there, all the amino acids will be consumed up, okay, as a result of catabolism. Catabolism means your body is breaking down its own stores to survive, okay. So the plasma albumin level, serum albumin levels, they all go down. And because of which immunoglobulins will not be produced, okay. For immunoglobulins, that is supposed to give you immunity. Serum albumin levels, okay, amino acid levels, they should be normal. Only then your body can produce those antibodies and immunity, okay. Lipid metabolism, in kwashiorkor, fatty liver is a situation that happens. Does not happen in marasmus, but in kwashiorkor. So excess of fat, which the body is not utilizing, will be deposited on the liver. It will lead to fatty liver. And if fatty liver happens, the liver functions go down. Okay. Liver is supposed to hold on to certain degree of fat. If it is overloaded, okay, by fat droplets, it will not be able to function properly. So metabolism, bile secretion, these things will be affected. Carbohydrate metabolism, your blood glucose level are usually normal, except in case of complications. Okay, in that situation, blood glucose level can go down severely, but otherwise it remains normal. Glucose tolerance is also normal. The more carbohydrate you give to the child, it is not manipulating the blood glucose level uh, to a very high or it is not taking it too low. Okay, the blood glucose level also after having food, it pretty much sort of stays in the reasonable level. Okay. Electrolyte and water metabolism. Potassium deficiency increases because there could be diarrhea, there could be vomiting, because of which they must be losing a lot of water from the body. Along with that, electrolytes is also lost. So potassium becomes a electrolyte which is easily lost. Okay, body can still hold on to sodium because of water retention and all, but potassium is easily lost. Vitamin A, very important in case of malnutrition. Vitamin A prophylaxis has to be given as quickly as possible, because otherwise it could lead to a situation in which the child can go blind. Okay, the child can go blind if immediately vitamin A prophylaxis is not given. So coming to the treatment, nutritional requirement, you are supposed to provide under the clinical management. There is a segment, we will come to that later. So children should be given appropriate levels of protein and glucose and fat, that is not only meeting their nutritional requirement, but that should help them to uh, fast forward their growth catch up. Okay, so that they can jump start directly to where their peers are, healthy peers are. Okay, not just fulfill their nutritional requirement at present, but what they have lost in terms of growth through food, you want to accelerate the growth. Okay, so that is also a target of nutritional requirement for malnourished kids. So foods that are especially rich in protein uh, or protein concentrates, you don't have to completely depend on that. A balanced meal under the clinical guidance can help a lot. Okay, kids who have kwashiorkor, they recover quickly as compared to children who have marasmus. Okay, a child who has marasmus, they take a longer time to recover and gain their weight and do the growth catch up. That is very that takes a longer time in marasmus, but kids who have kwashiorkor, they can come back to normalcy quicker. So energy requirement, at least 150 to 200 kilocalories of energy per kg body weight should be given. For children who are less than 2 years of age, 200 kilocalories per kg body weight is given. And for older children, 150 to 175 kilocalories per kg body weight. So based on the age of the child, calorie intake is decided. Malt and all can be given. And 50% of the calories should ideally come from carbohydrates. The remaining can come from protein and fat. Protein, at least 5 gram of protein per kg body weight per day should be given. 5 gram of protein per kg body weight per day. So the child can take cereals, pulse, vegetable protein like milk, because milk protein helps a lot in reversing any manifestations of severe acute malnutrition. A mix of vegetable protein and animal protein. Okay, a mix of these two is the ideal, because protein requirement can come from milk, but uh, to increase the serum albumin levels just with milk, that is not possible. Okay, so vegetable based protein can help with increasing the serum albumin levels, and growth can be overcome through milk. Fat, 40% of the total calories can come from fat. So 50% from carbohydrates, 40 from fat, 10% can come from proteins. So saturated fat like coconut oil, buttermilk, butters, okay, they are used because unsaturated fatty acids can lead to diarrhea. So saturated fatty acids are relatively well tolerated. Electrolytes, potassium chloride through IV infusion, magnesium chloride, they are added to the diet either through supplements or through, if the child is admitted through IV therapy, it can be given. In vitamins, vitamin A is given, oral administration is done. 50,000 international unit of vitamin A should be given on day 1, and that has to be continued for the next 2 days. And after 2 weeks, the same dose has to be continued. But again, the age of the child matters here. And then we have the management. There are 3 stages of management. Initial treatment, in case of complicated severe acute malnutrition, initial treatment is done in ICU. Okay, all the life-threatening conditions has to be identified and treated. Okay, like dehydration, hypothermia, hypoglycemia. Okay, the child, if the child goes into coma, unconsciousness. Okay, so these are life-threatening conditions. It has to be immediately treated in a ICU setup. So initial treatment is usually in the ICU, in hospital, where specific deficiencies are also corrected. And feeding program is begun. IV therapy will be there. Under the doctor's prescription, what should be given, at what rate the child should have food, which type of food, which formula. Okay, everything will be under prescription, and that should be followed. That is initial treatment. Then you have rehabilitation. Again, the feeding as per the clinical guidance is followed here as well, but the child can be moved to general wards. Here, the child, our requirement is life-threatening condition has been removed. The child is safe, but now the child has to regain the lost weight, regain the growth. Okay. So mother is the main caretaker here, along with the nurses, but mother is the main caretaker here. In initial treatment, the main all the major care is given by the healthcare workers, doctors, physicians, pediatricians, nurses. Okay. But in rehabilitation, mother plays a central role in the child's nutrition. Then you have follow up. Here, the child has been discharged, but still the problem has not been solved, because just because you have discharged the child is going back to the same economic status. The child is going to the same conditions the child was when it was found malnourished. Okay, so follow up is required to see uh, if parents at home or the caretakers at home, are they following through the guidelines, or are they failing again. Okay, so follow up is very much required. So this is the treatment time frame. So with this, you can have an understanding how the different stages of management of malnutrition is divided into days or weeks. Okay. So the initial first 2 days, you can see the life-threatening conditions are being taken care of: hypoglycemia, hypothermia, dehydration, sepsis, severe infection, okay, electrolyte imbalance because of nausea, vomiting. Okay, that is taken care of in the first 2 3 days. Within a week, electrolyte imbalance, micro deficiencies, okay, because multivitamins will be given, that will start. And from week 2 onwards, okay, 1 week has passed, week 2 onwards, increase the amount of feeds that you are giving, because from day 1 onwards you can't just uh, push a lot of food into the child. Okay, the child's body will go into a shock. Slowly you have to introduce nutrition back into the child. It takes a week or so for the body to register that nutrition is coming. Okay, so from the week 2 onwards, the child will start to recover the lost weight. Growth catch up will take place. Okay. If the child was irritable, agitated, frustrated, and all, slowly the child will regain its senses. Okay, its emotions becomes more controlled. Okay, and after a month, at least for 4 weeks, 3 4 weeks, the child will be under the hospital, and after discharge, follow up will go on. Okay, as long as it is required. So principles of management: in case of dehydration, you can give the child ORS. Okay, you can make ORS at home as well. Take 1 liter of water. Take 1 liter of water. Boil the water. Let it cool down. Okay, and add 1 fistful of sugar and 1 pinch of salt. Okay, a fistful of sugar and 1 pinch of salt. Uh, lime juice is optional. Okay, so this is how you make an ORS at home. If you don't have access to the packaged ORS in emergency, this is what you can make. And throughout the 24 hours, okay, this 1 liter of water should be emptied by the child. Okay, so that's how you take care of dehydration. So that can be given, ORS can be given. Depending upon the level of dehydration, the physician will suggest how much packages, how much ml of ORS should go. So usually within every 4 to 6 hours, 200 ml, okay, or 70 ml, 100 ml every 2 hours, or 200 ml every 4 hours, like that, the physician will be prescribing. So that has to be followed. Then infections. Diarrhea, measles, they are often immediate cause of death in during the protein energy malnutrition. So if at all the child has infection, within week 1, it has to be sorted. If it is bacterial infection, give antibiotics. If it is viral infection, give antivirals. So along with the diet, along with the ORS IV therapy, antibiotics will also continue if there is an infection. Hypoglycemia, severely low blood sugar level, so low that it can be fatal as well. Okay. So in case of hypoglycemia, glucose water is prescribed, or giving milk also, because milk has lactose, that is carbohydrate, that can also help. Dextrose solution per kg, 1 mg of the dextrose solution per kg body weight, that is usually prescribed. The dextrose solution is a carbohydrate IV. Okay. Then you have hypothermia. The body temperature falls too low. Okay, the body temperature goes so low that it could be fatal. That is hypothermia. So usually children who have marasmus, they are at a risk of developing hypothermia. So here the child should be properly covered with blanket, IV injection of glucose, saline, blood transfusion should be given, and mother is ideally in charge of sleeping with the child because the child gets a lot of warmth through the mother's body temperature. So that can also help to bring up the body temperature. Then congestive heart failure. In case of severe anemia or if there is any complication in the IV fluid therapy, you are giving too much of IV fluids that the body undertakes it as an overload, cardiac overload. Okay, that could lead to heart failure. So in that situation, immediately code blue treatments will be started with digitalis and all. Digitalis is medications used for immediate blood flow in the heart to kickstart the heart muscles for immediate blood flow. Then coming to the dietary treatments, we have formula diets like F75, F100. So these are formula diets, okay? So formula diets, so F75 can give you 75 kilocalories per packet. F100 will give you 100 kilocalories. That's why it is called F75 and F100. The contents of this package almost they're the same, except for the flour that is used. Okay, and F75 a cereal flour is used, but in F100 there is no cereal flour. It's only milk and other vitamin mixes. Okay, so why these formal diets are given? Because as soon as the child is admitted during the initial days, their body is atrophied. Okay, their intestine and everything has been shrunken. It is not functioning properly. So if you give the child normal food, it will go in waste. Okay, the child's body will not absorb it. But the formula diets are formulated in such a way that even with that atrophied small intestine, large intestine, it can pick up on these nutrients. Okay, so that is the reason why formula diets are given. So you start with F75 because it's low calorie as compared to F100. It is low calorie and it has cereal flours and all. Okay, so it is well tolerated. So F75 is given in the initial phase and F100 will be given in the rehabilitation phase. If you remember the initial phase, rehabilitation phase. So in the ICU, usually F75 is given. Once a child has been moved to the wards, F100 will be given. So this is a mixed ingredients. You just have to add water to this premix and give it to the child in regular intervals as prescribed by the physician. So this mineral mix does not control iron because in initial phase, iron is not given. Only during the rehabilitation phase, iron can be tolerated by the child. Otherwise, because iron could lead to constipation issues. Okay, already the intestine is dysfunctional. You don't want to add on the dysfunctions. Then feeding on admission, as soon as the child is admitted, today is the child, today you found a child who is malnourished and the child got admitted in the ICU. Okay, how the ICU staff will deal with this situation. Okay, so you will avoid overloading the system with too much of food. Frequently, small amount of food is given, essential food is given. And if the child is very irritable and the child is too small, unwilling to eat or get fed, in that case, NG tube, nasogastric tube will be put into place, okay? And every 2 to 3 hours, as prescribed by the doctor, as guided by the doctor, feedings will be given to the child. Feeding after the improved appetite, that is, once the child has successfully elevated from the initial phase, now the child is hungry. Sometimes the child will ask for food. Okay, so there is improved appetite. The child is hungry and asking for food. So usually within 1 week, you should see this improvement. So as soon as you see the child is hungry, the appetite has come back, you shift from F75 to F100. And it is a gradual transition. You don't immediately shift. Slowly you will stop F75 and slowly you will add F100. And after that, deficiencies. Simultaneously, all these deficiencies also you have to take care of. Vitamin A deficiency. Prophylaxis is given if the child is less than 6 months of age, 50,000 international unit of vitamin A on day 1 and day 2. If the child is under the age of 1, above 6 months, but under the age of 1 lakh international unit of vitamin A is given. And if the child is above the age of 1, 2 lakh international units of vitamin A can be given on day 1 and day 2. So it is a very age specific dose, vitamin A dose, to prevent blindness because of nutritional deficiency. Anemia can be corrected with iron, either with blood transfusion or iron supplements during the rehabilitation phase. And nutritional rehabilitation during the ward days, okay, slowly you have to make sure that the child is catching up with the growth. Every day, slight increase in the weight is there, okay, that confirms the rehabilitation. Slowly making a shift from liquid diet to semi-liquid, then solid diet, okay, that is also progress in rehabilitation. Children who are under 24 months of age, under 1 year of age, F100 diet should be given every 4 hours, night and day. Even if the child is sleeping at night, put the alarm, and every 4 hours the child has to be woken up and the F100 diet has to be given. And slowly you will increase the volume of the F100 diet. The first time you may give just 10 ml. After 4 hours, you will wake the child, give 20. Then after 4 hours, give 30. After 4 hours, 40, like that. Slowly you will increase the quantity of F100, but every 4 hours you have to give. So mothers are responsible for this. Mothers as a primary caretaker. Then follow up. During the time of discharge, the next days to come with the child is given to the parents. So parents have to bring the child on those days to see the height, weight, cognitive development, reflexes. Okay, these things will be checked during the follow-up visits. So follow-up and everything is planned, and it is encouraged that the parents do the follow-up. And diet during convalescence, once you have discharged the child, when the child goes back to home, how can the parents maintain the health and not push the child back into malnutrition? So, whatever food at home you are preparing, increase the quantity of the food for the children. Calorie and protein requirement should be satisfying. At least add 1 teaspoon of oil or ghee on the food to make it calorie dense. Increase sugar intake, banana intake, ghee, milk intake, if they can afford milk. Okay, milk, egg, skimmed milk. Okay, if it is affordable, they have to on a daily basis give it to the child. Cereal to pulse mixture of 5:1 ratio. 1 part of pulse, 4 parts of cereal. That should be the ratio maintained for children. And go for locally available, easily digestible, inexpensive food during the convalescence phase. You can also give this nut diet that is a packaged. Okay, it's a peanut. It's a sweet peanut mixture, ready to use. Okay, you don't have to heat or knead or do anything. Just open the package and give it to the child. Okay, and the child will sit and eat it. So it is under FSSAI. It has been licensed by FSSAI, produced by NIN, National Institute of Nutrition, Hyderabad. Okay, so they had done extensive research on how to give a food that is very inexpensive, ready to use, no need of refrigeration, no need of cooking, nothing. Okay, just you have to cut the tear it open and give it to the child. The child will squeeze it and eat it. Play. Okay, and it will have milk powder, sugar, peanuts. Okay, and vegetable fat is there, vitamins and minerals, some antioxidants. These things are there to help the child for catch up in growth. Prevention depends on community awareness, because primary healthcare centers, ICDS, Integrated Child Development Scheme, okay, they have a lot of programs, they have a lot of budget to help the community overcome malnutrition. But is the community aware of these facilities? Okay, so that awareness is very important in the community. So health promotion, promote breastfeeding, importance of breastfeeding, importance of giving health education to pregnant and lactating women. Because during their health visits itself, these education on how to give food to the child, okay, importance of breastfeeding, these things will be taught during the antenatal visits, okay, because after giving the birth to the child, you can't say if the mother will bring the child to hospital or not for checkups, okay. So educating the mothers is very important, promoting breastfeeding, uh, teaching them about low cost weaning food which are affordable but they're very effective, okay, like ragi and all. Improve the family diet, because if it is a healthy family, it will be a healthy child. Educating the family members about nutrition, correct feeding practices, home economics on what to spend money on, what to not, okay, so that even if they are on a low budget or a very restrictive budget, they are not compromising on the nutrition. Family planning, spacing of birth, specific protection. The child's diet must contain protein and energy-rich food. Immunization schedule should be followed. Food fortification can also help. Food fortification means adding certain nutrients into the available food in the market, like salt and all. If possible, on a daily basis, milk and eggs, fruits like bananas and everything has to be given to the child. Early diagnosis and treatment, like periodic surveillance, treatment of infections, diarrhea, Do not delay in the treatment for infections, diarrhea, cholera. Prehydration programs for children, importance of ORS, importance of hydration, uh, distributing deworming anti-helminthic medications in the community, okay, especially in the community where risk of dengue, malaria, chikungunya, these are very common in those communities. Then ICDS scheme, Integrated Child Development Scheme, they fund and they take initiatives for from birthing till the age of 5, and also for adolescent girls, their nutritional requirement. Okay, there are a lot of schemes that ICDS is taking care of. Okay, from supplementary nutrition, immunization, minor illnesses, growth monitoring, health education. There's a lot of schemes that ICDS are putting their money into. Also, the nutritional status for lactating women, pregnant women. Okay. The nutritional education, mothers should be given all the advice of supplements, what to eat, what to avoid. Okay, what kind of food has to be eaten by herself, and what food to be given to the children. Importance of breastfeeding, spacing between kids, right food, when to introduce, how to introduce. Okay, this education has to be given to the pregnant and lactating mothers, new and young mothers. Okay, so that's about severe acute malnutrition. If you have any